in the chat. And as you probably just heard, this webinar will be recorded. So the high cost of undervaluing direct care work is a report that details the costs and far-reaching consequences of our collective underinvestment in our direct care workers. Because many of us know, Maine's direct care workforce is in a fragile state due to a fundamental undervaluing of care. Low government reimbursement rates for direct care mean that workers are paid low wages and face high rates of poverty, financial hardship, and burnout at work. But this has far-reaching consequences beyond those that are felt by workers themselves. Providers face chronic labor shortages. People receiving care struggle to obtain quality services or maintain trusted relationships. Family members of people who cannot access professional care must drop out of the labor force. Businesses lose workers at a time when it's already difficult to hire staff. State and federal governments incur more costs and have fewer resources available to invest in people and communities. And our healthcare system's capacity is stretched dangerously thin. So these costs will continue to rise until our state properly values care work and confronts the profound consequences of inaction. So in today's webinar, we want to just briefly touch on the following subjects. First, we want to get on the same page about what direct care is and how it's paid for. And then we want to dive into the economic impacts of our underinvestment on workers, consumers, families, employers, our healthcare system, and the economy at large. And then at the end, we'll touch a little bit on what we could do to remedy this situation. So now I'd like to introduce our speakers. Joining me is Josie Phillips at the Maine Center for Economic Policy, our State Priorities Partnership Fellow and a co-author of the report. Also with us is Jess Maurer, Executive Director at the Maine Council on Aging. We also have Jake McDonald, Senior State Policy Advocacy Specialist at PHI, which is a national organization focused on direct care workforce issues. And finally, we have Leah McAlpine, a direct support professional who's been in the field for nearly 30 years. So we're going to hear from all of our panelists along the way. We're going to throw a lot at you and try to just introduce you to the findings of this new report. And we ask that you drop any questions that you may have in the chat, and we'll get to as many of those as we can after we've gone through the program. So with that, I would like to hand it off to Jess to tell us a little bit about what direct care is and how it's paid for. Jess?
Well, thanks so much. And thank you to the Maine Center for Economic Policy for doing this report. It's really amazing. So direct care is broadly assistance and support with activities of daily living, like dressing, eating, showering, and instrumental activities of daily living, like grocery shopping, cleaning, changing a bed. One type of care is hands-on, the other is supportive. And depending on the population served, it might be care, support, or both. And it might also involve socialization, coaching, even employment support. The types of people served are older people, people with physical, intellectual, and developmental disabilities, and people with behavioral health challenges. The work might be done in the person's home, in a group home, or a residential care home. Most direct care and support is unpaid and provided by family members and even friends. Paid workers are not called in until specialized care is needed. The family is overwhelmed in meeting the care needs of the person. The care partner is employed, or the person has no family or friends to provide the care. And it's important to note that the caregiving workforce itself is really highly skilled, and they're a professional group of people requiring technical knowledge of personal health and specific knowledge about the care for the person they're providing care for, a particular set of needs. For instance, someone may be providing care for a person with dementia or supporting someone with autism, and they have to understand how those issues work and the kinds of care that a person needs or support a person needs. The work calls for physical strength often, and also significant emotional intelligence. Workers are typically women. They include a growing number of women of color, and like other sectors, this workforce is aging as well. Collectively, workers say they do this work because they care about the people they serve. They are really literally called to care. As a result of inadequate government investment in services for people who are aging, people who have behavioral health challenges, and people with intellectual and developmental disabilities, employers providing these services struggle to find and keep workers to meet the client demands, and workers in high-stress jobs receive low pay and often no benefits. It's important to know that unless a temporary need related to medical care arises, generally Medicare does not pay for any direct care or support services. So only MaineCare or Medicaid is the payer of services for people who need who are both medically and financially needy. While MaineCare is the primary payer for these services in Maine, the VA also pays for some of these services. There are also state-funded programs like the Homemaker Program and the state-funded Home and Community-Based Services Program. So ultimately, Maine, the Department of Health and Human Services, sets the reimbursement rates for these services, and the rates typically don't meet the actual costs for providing these services, leaving an employer hamstrung to pay staff a competitive wage in this tight labor market. To provide for their families and sometimes basic needs, many workers have no choice but to leave the work that they absolutely love for higher paying jobs in other sectors. Ultimately, because MaineCare and state-funded programs are available to only very low-income Mainers, most people have to pay out of pocket for these services. Maine has some of the most expensive home care and nursing home care in the country, and it's unaffordable for most households and individuals who will need to eventually have this kind of care. And even though it's very high costing work, the workers themselves continue to be undercompensated. This is really a price point issue, even though home care providers who don't take MaineCare can only charge clients so much before the service is unaffordable for most people. So the price point they charge drives the business model and how much they can pay their staff. So now I'm going to turn things back to Arthur to give a broad overview of the report.
Excellent. Thank you, Jess. I also just want to remind folks that if you do have questions, please put those in the chat, and you can also always follow up with us after this webinar. So again, this report is really an attempt at capturing the many overlapping economic costs to undervaluing the direct care workforce. And so as we jump into that, I'd like to hand it over to my colleague, Josie, who can get into what we've learned about the costs related to labor force participation, turnover, and how those contribute to lost economic output overall. Josie.
Thanks, Arthur. So the breakdown of the direct care workforce is exacting a serious toll on our economy and the direct care workers themselves. Some costs, like lost economic growth and turnover for businesses, are relatively easy to quantify. Others, however, such as the mental and physical toll on clients, their families, and direct care workers, are more abstract, but no less real and certainly no less important. And we know that these costs are substantial. The costs to Maine's economy from workers who dropped out of the labor force to provide elder care amount to over $1 billion per year in lost GDP. In addition to this, increased turnover related to care responsibilities costs Maine employers tens of millions of dollars annually. And we know that these estimates are almost certainly undercounts, as they don't include absent workers who are caring for loved ones with behavioral health issues or disabilities, for instance. And it also excludes the cost of employees dropping down to part-time work or being less productive at their jobs as they're trying to balance multiple responsibilities. In addition to being a drain on the broader economy, inadequate reimbursement for direct care services also takes a significant toll on the workers, who are forced to accept low pay and little access to job benefits like paid time off or health insurance. Even when considering recent laws that increased average direct care worker pay, the increase is only slightly above the living wage for a single person with no dependents, and is far less than the wage needed to support even one dependent spouse or child. These job conditions, defined by low compensation, then make it difficult for employers in the industry to attract and retain a quality workforce, which leads to high turnover rates and a reliance on short-term staffing agencies, which cost more in the long run than traditional workers. We estimate that the costs of employee turnover within the direct care industry alone to be between $50 and $75 million per year. So we know that the problem of undervaluing direct care workers carries significant costs to employers and the broader economy, costs to the health and well-being of people who need care services, their families, and the workers who provide this care, and costs to our government and hospitals. And so on that note, I will turn it back over to Arthur to discuss those costs to our state and federal governments.
Amazing. Thank you, Josie. So I think, as Josie suggested, I think another underappreciated cost of undervaluing care work is the significant costs on our public benefits at the state and federal level. So in this report, we looked at this in a couple of different ways. One is from the drop in labor force participation resulting from workers' direct care responsibilities and their inability to find professional support, which means, as Josie said, fewer workers are contributing taxes. Fewer workers are in the labor force and contributing taxes. Second, because direct care workers are paid low wages, they have to rely on public assistance programs, including MaineCare and Supplemental Nutrition Assistance Program. So first, let's very briefly look at the cost of dampened labor force participation. As Josie suggested, underinvestment in direct care and support workers is keeping more than 8,000 Mainers out of the labor force. Again, as people have responsibilities to their families who need support but cannot find professional care, they're pulled out of their own jobs. So the cost of those workers' tax contributions to the state of Maine, we estimate, is more than $13 million a year. And at the federal level, we estimate that the cost is around $34 million in lost revenue. So altogether, the impact on labor force participation amounts to about $47 million in lost public resources. Then if we look to how low wages lead direct care workers to rely on public assistance, this represents another significant cost. So looking just at MaineCare, Supplemental Nutrition Assistance Program, and temporary assistance for needy families, low wages for direct care workers cost public budgets another $25 million. So taken together, we estimate that these costs cost our state and federal budgets more than $70 million each year. So I think what Josie and I are trying to illustrate is that the costs of addressing the direct care worker shortage are, some may argue that they're too high to tackle. But we want to get across is that the costs of failing to address the issue are even higher, and they'll be borne by everyone throughout our state. So with that introduction to some of the findings of the economic impacts, I'd like to introduce Leah McAlpine, a direct support professional, to tell us a little bit about her experience in the field. Leah.
Hello, thank you for having me, and thank you all for completing this comprehensive report on our behalf. I have been in this field for 29 years. I was the Maine Direct Support Professional of the Year for 2022. I won a second award that year in recognition of 13 DSPs in the country who go above and beyond. The focus of my nomination was the work and advocacy I pursued in order to get iPads to folks who were segregated in their group homes when the pandemic first hit. I led efforts to teach people supported and staff the skills needed to attend Zoom meetings and watched people enjoy long overdue social connections during the pandemic. Like many elders in Maine, I found that people with disabilities were far behind in the use of technology to stay connected and to assist in other areas of independence. I started at OHI when I was 19 years old, working myself through college to become a special education teacher. I stumbled upon a job at a day program in 1994. We taught adults with disabilities to learn about cooking, going out in the community, money skills, exercising, socializing, and pre-vocational tasks. Their group home staff dropped them off, and I was there to teach them until they went home. I was hooked. Working with adults was what I wanted to do. I earned a degree, but chose to continue supporting adults with disabilities to live productive lives in their communities. I was briefly a job coach and also worked in our training division, but found that I missed working with the people. I was a supervising and on-call manager for about 6 years, but still wanted to do more with the people work rather than the paperwork, scheduling, and on-call responsibilities of a supervisor. I made a choice to step down and become a full-time DSP. I see what I do as an extension of the special education setting. I teach people how to live the life they want. No other healthcare worker does the same thing we do. Let me repeat that. No other healthcare worker does what we do. I find job satisfaction in the fact that I am an essential employee. When the world shut down, I had a special pass in my card giving me permission to go to work. The people we support cannot go without staff to support them. They do not have the skills to be independent and keep themselves safe, and there are not enough of us to go around. The worker shortage has been going on for decades, but became even worse when the pandemic forced people to stay home and take care of their own families. As just mentioned, direct support professionals work in a variety of settings. I work at group homes, but care workers may also work in family homes or in shared living provider homes. Families and shared living providers become care workers, and they also require additional care workers to help provide all the supports needed. Some people with disabilities live in their own homes or apartments, and staff go in daily or occasionally to provide a variety of support to help them maintain their independence. This is the ultimate goal. We are also job coaches working with people at their job sites, and some DSPs only do community-based work, teaching people skills in the community and building relationships and support to meet their goals of being independent of staff and out on their own. We are everywhere. We are open 24 hours a day, 7 days a week. We never close. We are not a typical 9 to 5 home by supper kind of worker. We always have to maintain a certain ratio of staff to people supported. If staff doesn't show up to relieve us, we cannot leave until another staff arrives. Some homes have staff sleeping in a staff bedroom. Other homes have overnight staff that stay awake all night. And some homes have both a sleep staff and an awake staff. Most homes need 1 to 4 staff per day in order to get out. Most homes don't get that many staff unless we pull them from another home and put them down by one. A typical day in a group home involves basic activities of daily living. Everything you and I do, they need someone to help them do. We are gloves on, assisting with hygiene routines and personal care. We assist with personal and household chores at whatever level each person needs. Some are more independent, some need lots of encouragement and prompting, and some need hands-on or complete assistance. If there are doctor's appointments or shopping, we do that with them and help them communicate. Some people manage their own money while others rely on us to help them budget, spend, and document their finances. Some people may go to a day program or go to work for a couple hours, but many, many more just stay home all day. Some people have good communication skills. Others may use limited sign language or gestures and behaviors to communicate their needs. Staff encourage people to participate in household chores and meal preparation as much as possible, but often take the lead role in maintaining the overall care for the home and for the people living there. Some people in group homes have a natural support system like family, but many others do not have any family or friends outside of paid professionals in their lives. That is the goal of the HCBS settings rule, to develop and enhance natural and technology supports available to all people for social and employment opportunities for people with disabilities. We just aren't there as consistently as we should be because we don't have enough people to provide those meaningful opportunities. Most of my Saturdays are split between multiple group homes so that everyone gets out, gets their medications, and gets outside of the group home setting. I'm getting lots of basic needs met, but how meaningful is it in the grander scheme of things? So in addition to all the care I've just mentioned, there's also a great deal of paperwork and office work for licensing and billing. We order, store, and administer all the medications in the home. We organize all medical appointments and follow-up care. We work with public and private guardians, as well as case managers, to get consent and permissions when the person is not their own legal guardian. We must document all of the services and supports that we provide daily based on individualized plans and personal goals. Further, we are required to provide proof that we are following the HCBS community rule. It is a great deal of work and can be overwhelming to some staff who may have a preconceived idea that they are only coming to provide a caring environment. It's a lot more than that. The community rule insists, as it should, that we are making meaningful relationships outside the walls of the group home, but we cannot always accomplish this when staffing levels are at a bare minimum. We struggle to educate the community that we are seeking those meaningful relationships, both for employment and for human level social connections. Some people have no one who is not paid to support them. And during this crisis, they have had to endure a larger number of new staff who come and go from their homes as they continue to sit and wait for who may show up next and wonder, will they stay? Unfortunately, going through the drive-through has become the norm. There isn't enough staff to adequately supervise everyone if they get out of the van. This isn't meaningful. This is barely getting by, and this goes against everything we are trying to accomplish. They have the right to access the community as everyone else does, yet they cannot access the community or get a job or find a friend or go to church because we do not have enough workers or other natural supports in the field. We need to breathe some life back into this broken workforce and engage the community in our mission. Lastly, I want to speak about the quality of life that the workforce crisis has on all of us, including our families. There has been significant increase in anxiety about staffing, and we all feel it. The people supported are often worried about which staff are coming and whether they're going to get pulled to another location. Staff have the same concerns. Will my coworker be trained at this location? Can they drive? Can they give medications? Are they brand new and need me to mentor and train them as well as the people I support today? I anticipate every day that I will get pulled to another location. Our family members wonder if we're coming home, and at the end of each shift, and every time the phone chirps, they wonder if work is trying to call us back in. We aren't technically on call as DSPs, but that doesn't stop managers from reaching out to us 7 days a week to come back to work. It's a vicious, unnecessary cycle of worry and concern that can be relieved by enhancing our workforce. It would be worth it to pay people more to choose this career than to leave us in a state of crisis and continue paying extraordinary amounts of overtime and burning staff out and forcing them to consider leaving a job they may actually love doing. I do not regret my choice 30 years ago to forgo a teaching career. In fact, I take pride in my ability to teach people every single day. I teach the people we support, I teach my coworkers and new managers, and most importantly, I teach the community how to interact with the people we work for. I would love to offer any public official to ride along with me for a day. I will help you see the value of the work we do as essential frontline direct care staff. Thank you.
Thank you so much, Leah. Really appreciate you sharing your perspective and for all of your service. So now I'd like to hand it over to Josie to tell us a little bit about the impacts of the workforce shortage on families.
Thanks, Arthur. When people are unable to afford the care that they need and don't have access to supports, paying for or directly providing care often falls upon the person's family. And this can take a mental toll on the family caregiver. After all, as we've heard, this kind of care that direct care workers provide is difficult, skilled work. So it's understandable how suddenly being expected to provide it to a family member can be overwhelming when you haven't had that training or preparation. This stress can put family caregivers at higher risk for conditions like depression or anxiety, and in some cases, it can strain the relationship between the caregiver and the care recipient. For family caregivers who end up dropping out of the labor force to care for a loved one, this may also have serious financial consequences for them. Long gaps in resumes make people less likely to be hired, and even when they are hired, their earnings are often significantly decreased. Between the missing wages while caring for the family member and the decreased earnings upon re-entering the workforce, this can add up to a serious drain on lifetime earnings, which can then go on to impact the caregiver's financial stability in retirement. So through these impacts, the direct care worker shortage is a significant challenge to many families' mental and financial well-being. Nationally, 1 in 6 adults report providing care for a loved one, and a recently released report from the AARP estimates that there are 166,000 family caregivers in Maine who provide more than 150 million hours in unpaid care each year. And as Arthur mentioned before, according to our estimates, the failure to adequately invest in direct care and support workers is keeping more than 8,000 Mainers out of the labor force. So alleviating the direct care workforce shortage by fairly compensating providers and workers would help to alleviate some of this strain felt by family members who may be struggling to balance the needs of their loved one with their own health and financial needs.
Great, thank you, Josie. So we've heard about the impacts on labor force participation, on workers, and on families, and now I want to hand it over to Jess to speak a little bit about the impact on consumers of direct care.
Great, thank you. Thank you, everyone. So the undervaluing of this workforce and the resulting workforce shortage is leaving vulnerable people significantly more vulnerable and without real choice in setting as required by law. For instance, people who are supposed to be receiving home care under Maine Care Section 19 live at or below poverty and are eligible for nursing home care. These are mostly women, and they have elected to stay at home. Because of staffing shortages, however, 33% of them are not getting the care they are entitled to, and some aren't getting any care, which means they are more likely to end up in the hospital and ultimately in a nursing home where they do not want to be. For those who don't qualify for government assistance, people will be forced to sacrifice their health or financial stability to afford the care they need to remain in their homes. These folks also may experience avoidable health problems and injuries due to their inability to find or afford care, potentially resulting in hospitalization and ultimately untimely entry into long-term care. Critically important, though, is the fact that nursing homes and other residential care facilities are struggling to keep staff as well, meaning beds are offline and unavailable for people who need them. Currently, nursing homes are only at a 78% occupancy rate due to staffing shortages. Underinvesting in these costs in the less costly home care leads to far greater social, financial, and healthcare costs when it undermines the ability of hospitals to provide care for acute illnesses and results in people being institutionalized sooner than they need to be. In relation to folks with intellectual disabilities that Leah were talking about, I want to emphasize some really important information provided around the scope of this problem and then the kinds of impacts that Leah was talking about. The Maine Association for Community Service Providers, MACSP, is a statewide association of providers offering supports to people with intellectual disabilities, autism, and brain injuries. They conducted a membership survey in January of 2023 to better understand the issues facing this workforce and their clients. They found that 86% of respondents reported having open staff positions, collectively amounting to 941 openings. If fully staffed, respondents projected they could provide supports to an additional 1,644 children and adults. In December 2022 alone, staff in non-group home settings worked a total of 6,600 hours of overtime, the equivalent of 165 full-time workers. 34 group home service providers reported that in the last quarter of 2022, their employees worked 250,000 overtime hours to meet minimum staffing requirements, the equivalent of 521 full-time workers. There is also no doubt the situation is not sustainable as workers burn out from working so much overtime, meaning eventually clients will go without staff or these providers will have to close, resulting in the same situation. In fact, nearly half of these organizations reported having to downsize, temporarily close, or permanently shut programs in the last year. The primary cause was overwhelmingly identified as staffing issues stemming from inadequate reimbursement rates. For people with intellectual disabilities, autism, brain injuries, who are supposed to be getting support with living independently, socializing, engaging in activities that are meaningful to them, this means limiting what people do, how they live, or even whether they can be productive in the workforce. The big picture in relation to these two populations and many others is the system is interconnected and it's collapsing, leaving it unable to meet the needs of people who need all kinds of care. Unless we make significantly greater investments in the full continuum of care, the situation will only grow worse. I'll turn things back to you, Arthur.
Thank you very much, Jess. So I want to just very briefly address the impacts of the direct care workforce shortage on our state's healthcare system. So delayed discharges occur when someone who is in an acute care hospital has been deemed appropriate for continuing care in a non-hospital setting, but they continue to occupy a hospital bed. These delays occur when a direct care and support worker is not available to support that person's ability to safely return home, or when nursing facilities are closed or operating at a lower capacity due to inadequate staffing. And these delayed discharges have a ripple effect across the entire healthcare system. So on the individual level, they have been associated with myriad negative outcomes for the person awaiting discharge, including increased rates of infection and injury, depression, and social isolation. And on the broader sense, it imposes a really significant cost on hospitals and our healthcare system. So one view into the cost of delayed discharges comes from Maine's long-term care ombudsman program, which advocates on behalf of long-term care consumers. So last fiscal year, the long-term care ombudsman program received 217 referrals from hospital patients facing barriers to finding suitable care outside of the hospital setting. I think it's fair to say that these 217 referrals represents just a fraction of the number of people statewide facing this issue. But among those people, nearly 2/3 of them took longer than 30 days for them to be discharged after the referral. And more than 1/3 of all those referrals took longer than 60 days to resolve. Another way of getting at this is by seeing the impacts on our hospitals. In March 2023, the Maine Medical Center had about 50 people under its care who were approved for discharge but could not find an alternative care setting, and that was just one point in time. For Northern Light Health, they noted that over a nearly 6-month period, the cost of delayed discharges across the system's hospitals totaled more than $13 million and amounted to approximately $63,000 per person. So now I'd like to turn things over to Jake McDonald of PHI to tell us about Maine's experience and how it compares to what he is seeing elsewhere in the country. Jake.
Thank you, Arthur. And thanks everybody for being here, engaging in this report. I want to offer a viewpoint from a national organization which has been working across the country and at the federal level on these issues. Maine is unique in that it is the state with the oldest population. So the need for long-term care services here is just tremendous. It's also the most rural state in the country, and that means there's lots of challenges making sure there's enough workers to help those who need care, no matter where in the state their home is. Because of these things, Maine has been, and we think will continue to be, a national leader in driving the changes that need to happen to make sure everyone is getting the care they deserve. Recently, we at PHI reviewed direct care workforce policies in every state in the country, and we ended up ranking Maine in the top 5. And this is because Maine advocates have had incredible success in strengthening the direct care workforce, including by significantly raising wages, providing access to free training and easier credentialing process, creating career pathways for the workers, and establishing the Long-Term Care Workforce Commission. But while Maine's demographics might be unique, all over the country, states are running into really serious both human and economic problems because of a lack of investment in direct care jobs. Nationally, PHI is helping to support the workers and advocates and the employers and lawmakers in trying to tackle these problems. And there are solutions from other states that Maine can pick up and will really need to, because Maine's demographics make the next few years critical for Maine's economy and also the well-being of its people. So for example, Maine needs better data collection to truly see what's happening. So who isn't receiving services? Where are workers needed? How can we better define the occupational code so we know what workers we're talking about? These are questions we need to answer so we can better fit the solutions to the problems. And while Maine has made significant strides in better valuing direct care workers, there is so much more that can and should be done, from continuing to increase wages to ensuring these are quality jobs that can attract and retain the workers we'll need now and in the future. So for more on the solutions that are presented in this report, I'll hand it back to Josie.
Thanks, Jake. So now that we've established where we are and how much the undervaluation of direct care is costing us, I want to talk about where do we go from here. And as Jake mentioned, the first step towards addressing this problem is to gather information that will allow us to better understand the scope of this problem. But the second step, which is just as important, is to increase reimbursement rates for direct care services to allow providers to fairly compensate their workers. To help this happen, we encourage people to get in touch with their elected representatives to let them know that Maine cannot afford to continue to undervalue direct care or the workers who provide it. By properly investing in the workforce to ensure the availability of relatively lower cost options such as home care and adult day services, Maine can create breathing room throughout the care continuum and enable more people to receive the care they need in the setting that's most appropriate for them. The price of failing to act now, as we've laid out, is too steep. Legislators and advocates across the state have begun to wake up to this reality, but more work remains to adequately bolster the foundations of this crucial sector of our economy before the structure gives way. And on that note, I believe we will be moving to questions and answers.
Yes, thank you, Josie. So I just want to, I think first I'll go maybe back to you, Josie. Wanted to just ask you what you thought in doing the research and writing this report. What were some of the most surprising findings for you on the impact of the undervaluing of the direct care workforce?
Yeah, so I think the most surprising finding for me was learning that the estimated cost of lost GDP was over $1 billion, because walking into this project, we knew the price tag was going to be steep. We knew that this was having a significant impact on our economy. My just personal estimates going into it was going to be in the hundreds of millions. But learning that it is over $1 billion and that over $1 billion count is likely a severe undercount, I thought was just more staggering than I had anticipated.
Thanks, Josie. Next, Jess, I wanted to maybe turn to you and welcome others to jump in if they'd like, to speak to what regular folks can do to take action or to kind of support more properly valuing the work that direct care workers do.
Sure. And this comes up all the time. And one of the most important things that I think regular people can do, this is impacting everyone. And if you just have a regular conversation with anyone at your workplace or in your family or in your friend setting, and you bring the subject up, people connect with it immediately. People are really experiencing this challenge real time, and they don't realize that there are many, many other people who are experiencing. So this is the individual problem versus the systemic problem. And we need to shift people away from thinking that it's something that they have done or they haven't done that's causing them to not be able to get care, and to begin to be advocates, right? We need people to tell their story. And I think we're going to share a new website that we've created for this new partnership that has come together to continue to work on these issues over the next probably decade, but several years to implement this. So telling your story and then really getting involved. Talk to your legislators about your challenges to remain employed in the traditional workforce and provide care. To find care, write a letter with a stamp, not an email, a letter with a stamp to the governor to say it's time to urgently respond to this. The urgency seems really missing here, that there are so many people, thousands, tens of thousands of people who are going without the care they need, who are really being harmed and dying. And so let's, kick up the urgency. And we can only do that if regular people who are experiencing these challenges get involved. And then finally, I'll say, talk to your employer, or if you are a business owner or employer, share this report with your HR director or your employer and get involved. We really need private-public partnerships. Josie just talked about Adult Day to make investments in the care infrastructure. Ultimately, there may not be enough workers in Maine to provide care to everyone in Maine that will need it. And so we may need to pull, as in, P-O-O-L, the resources through programs like Adult Day programming. But we have actually 5 counties in Maine where there are no adult day centers anywhere. So we need to invest in the care infrastructure all around Maine, much more locally. We need employers to become involved, to realize that they are losing workers, to think about benefits, elder care benefits, for instance, or better leave policies for workers who are experiencing these significant challenges. But mostly we just have to shine a light on how people are being impacted by hearing directly from all the tens of thousands, hundreds of thousands of people in Maine who are being impacted.
Thank you, Jess. And I'm seeing one more question about how might the enactment of a paid family and medical leave law impact some of these direct care challenges? I think that's a great question. I think that, Jess kind of earlier in the program talked about the continuum of care, kind of how many different populations of people are touched by the direct care workforce, and how many different scenarios are covered. And I think that to support, Jess just spoke to the challenge of being able to actually draw on a sufficient number of workers to address the need that we have in the state, which is only going to become more challenging in the years ahead. Obviously, a really significant piece of that is properly valuing and compensating that work and really honoring the work that folks like Leah and other direct care workers do. But we can, support that work by enabling people to leave their jobs for just temporary leave when they need to, when a family member is in an acute situation where they need, much more hands-on support and where it would be appropriate to receive that support from a family member. So I think we see the paid family and medical leave program as being a complement to the system that we have. And I think that those investments support one another in a really direct way. So I appreciate the question. I think that we're gonna leave it at that. I want to thank everyone for joining us, and I really want to thank Leah and Jess and Jake and my colleague Josie for being here. We appreciate any questions that you may have as follow-up. A link to the report was just dropped in the chat. If you didn't have it already, you can always reach out to us at info@mecep.org. And a reminder that this event has been recorded. It'll be shared out to anyone who wants it, who's been registered for the event. And thank you again for being here. And thanks again to our guests. Take care.